Good afternoon, ladies and gentlemen. I am Dr. Sukanya, scientist at the ICMR Institutional National Center for Disease Informatics and Research. We work on the areas of developing databases on non-communicable diseases to strengthen disease surveillance and research in NCDs. We work in collaboration with a network of hospitals across India. We innovate using epidemiology, statistics, and IT tools as our core areas. And we inspire to make an impact on the national policy and programs on NCDs. Today, we have all gathered here and I welcome you to this public webinar on lifestyle and non-communicable diseases to commemorate India's 75 years of independence celebrations, Azadi Ki Amrit Mahotsav. And this grand event kind of culminates our Prime Minister's focus on citizens to bring back citizen participation as the main core area. And we take at ICMR this occasion as an opportunity to showcase our research work to the citizens of India. We're very glad that many of you have joined, includes a lot of our advisory members, scientists, senior scientists and experts, students, faculty across medical colleges and citizens. I welcome you all to this webinar. I especially welcome our eminent speakers, Dr. V. Mohan from the Madras Diabetes Center, Mrs. Jyotsna Govil, the chairperson of the Indian Cancer Society New Delhi chapter, Dr. Dheeraj, Associate Professor, Psychiatry at CMC Vellore, and our director, Dr. Prashant Mathur. We are gathered here to listen to these eminent stalwarts, all of them experts in their own field of work, and they will enlighten us about lifestyle and the intersections with NCDs. For many of you, I just thought I'll explain a little more about ICMR NCDIR. We are in a decadal year and we've conducted several webinars on NCDs, and this is one of them, especially because today's topic is familiar with all of us, yet a difficult topic to manage in our individual lives, in our families, and also in community at large. It's my pleasure at the outset, to kind of moderate this important webinar and try and learn from our eminent experts and speakers who have come here today to share with us their knowledge and expertise and experience. At the outset, I request all of you to stream the webinar through the Zoom link or the YouTube link, which is available, and drop in your questions at the Q&A box. We will take up all your questions in the end of the talks. All of you know non-communicable diseases are a major burden to individuals, communities, and the nations and countries across the globe. And there are 4 risk factors which are very, very crucial. These are the unhealthy behaviors of tobacco, alcohol, inadequate physical activity and improper diet. And these impact the other levels of disease conditions and unhealthy health status. Today we have with us Dr. Prashant Mathur, Director ICMR NCDIR, who's a public health expert on NCDs, on NCD risk factor estimations, measurements, and he's part of several initiatives within India and internationally on NCD prevention and control. Dr. Mathur will explain to us about the evidence on risk factors and NCDs and the need for action. His motto is that data cannot stand alone and needs to be connected to action, both policy and programmatically. I welcome you, Dr. Mathur, to give us your talk on risk factors and NCDs, and I invite you to present your slides and talk. Over to you, sir.
Yeah, thank you, Dr. Sukanya. And on behalf of the Institution National Center for Disease Informatics and Research, I welcome all the participants who have joined and look forward to many more of us joining over here. And a big welcome to our eminent panelists who will be sharing their knowledge, wisdom, and ground root experiences on tackling these diseases. So I'll begin by sharing my slides. I hope they are seen on full screen.
Yes, sir, very well. Yes, sir. They are seen.
Okay. So Azadi Ka Amrit Mahotsav is the call given by the Honorable Prime Minister And this is an opportunity to enlighten our citizens for any discipline, any part of the country, on what the country has done and what the country needs to address, so that we begin a big march towards the successful decades of the country. The NCDIR has been working on non-communicable diseases, and we would like to showcase some of the reasons why we have organized this webinar. We have work around many of the non-communicable diseases. The flagship program is the National Cancer Registry Program, which has been running since 1981 and has been providing robust data on cancer statistics from across the country. Then we have also initiated work in the area of stroke, diabetes, heart failure, also strengthening cause of death, medically certified cause of death, and have been involved in conducting several risk factor surveys at national level and at subnational levels. Please visit our website to get more information on the contributions that we have been making. This is an old Maratha warrior call and an understanding: strike the roots and the tree will fall off. And this is where I would like to begin by saying that non-communicable diseases, what you see as the branches, and they are several diseases together, like stroke, kidney disease, diabetes, neurological disorders, cancer, mental health, cardiovascular disease, and so on and so forth, are connected by the common trunk of many risk factors. And the roots lie in many of these determinants and social factors which govern these occurrence of the risk factors. As you can see that this is a plethora, and compare it with the typical infectious diseases where you have one parasite, one virus, one bacteria causing one disease. But here you have a plethora of such agents causing not only one disease, but multiple diseases. So it is prudent that we need to recognize, because risk factors of today are diseases of tomorrow. And so if we have to be alert in non-communicable diseases, we must strike at the risk factor so that they do not become diseases or they retard the progression of into a disease stage. We know that globally, non-communicable diseases are a major cause of premature death. Premature death means death which is occurring between 30 to 70 years of age. Our life expectancy over the decades has increased tremendously, but the successes achieved in the life expectancy should not be curtailed by some of these preventable and avoidable diseases. As you can see that countries in the either low income or low middle income countries suffer from a very high proportion of premature deaths as compared to the high income countries. Almost twice is the difference. Also, the probability of dying from cardiovascular diseases, cancer, diabetes, chronic respiratory diseases is much higher in LMICs and other low middle income countries. And this stark scenario reminds us that there is a great inequity happening, and the roots lie in getting these risk factors converted into diseases into call for appropriate action. So what does these risk factors do? The risk factors have been studied well. So on the top side, you see some of the non-communicable diseases with which you are familiar with listed. And on the left column, you can see the risk factors and the proportion of attribution of these risk factors to these diseases. And so what I said earlier, that each risk factor can give rise to multiple outcomes of diseases. For example, tobacco is involved in diabetes also, in stroke also, in chronic obstructive or respiratory diseases, cardiovascular diseases, cancer, and so are other risk factors like alcohol consumption, diet which is low in fruits and vegetables, diet high in sodium content, low physical activity, raised fasting blood glucose, overweight, obesity, household air pollution, and the list goes on. But these are the major ones which are causing the major contribution to the non-communicable diseases. And so in response to the call of the United Nations and the World Health Organization, in 2014, India also formulated its national NCD monitoring framework and a national NCD action plan. So what we have to achieve by the year 2025 are these 10 targets, which are shown on the left side, which address issues like tobacco, alcohol, diet, physical activity, sodium intake, overweight, obesity, household air pollution, also looking at systemic issues of availability of medicines, technology, devices. So there is a morbidity and mortality issue, there is risk factors, and there is a national system response. These need to be put in unison so that they act together and we will be able to mitigate some of these non-communicable diseases. In response to this National NCD Monitoring Framework, NCDIR undertook a National NCD Monitoring Survey, or NNMS, in the year 2017-18, and with the objective to generate a lot of information around these indicators, which I just showed, which are on risk factors and health systems response. And this report is available on our website for anybody to go through with other more details available there. So what do we see in this report? Let's start from the left. The current daily tobacco use in any form, whether it is smoking or smokeless tobacco, 28% of our adult population, that means 18 years and above, consume 28% of tobacco in any form, more men and slightly more in the rural areas. Alcohol use is almost 16%, more among men, and not much difference between urban and rural areas. Insufficient physical activity, that means 150 minutes per week. So there are criteria of defining what is the optimal physical activity. 41% of our adult population does not do adequate physical activity. The problem is more among women, and it's an urban phenomenon. Though when I say this, it doesn't mean that men and rural areas are free of it. They are there. The salt intake. This was the first time in the country that we undertook a national level study on the salt intake in our diet. On an average, an adult Indian consumes 8 grams of salt per day. The recommendation of the World Health Organization for a healthy living is to consume 5 grams of salt per day. So we know from 8, we need to reach to 5 at least. More in men, but not much difference in the rural and in the urban areas. We are uniformly, whether it is urban areas, rural areas, men or women, we consume less than 5 servings of fruits and vegetables per day. That is the recommendation. But this is a huge gap. And when I say vegetables, it does not include roots and tuber fruits as per vegetables, especially potatoes. Now looking at some more complex risk factors, the overweight and obesity. 1/4 of the adult population is overweight and nearly 6% is obese. It is again more in the women and an urban phenomena, but rural will catch up soon, and it is there in substantial proportion. Blood glucose. Let us say 2 variables, raised blood pressure and raised blood glucose. This is fasting blood glucose. 28.5% of our adult population had raised blood pressure and 9% had raised blood glucose. Again, we do not see much of a difference, though it's little high preponderance in urban areas, but the difference is hardly perceptible between rural, urban men and women. Looking at abdominal obesity or the obesity around the central part of the body, 32% were centrally obese. This has tremendous impact on our cardiometabolic health, and lot of disease outcomes, including diabetes and cardiovascular diseases, more in women and more of an urban phenomenon. We also looked at what proportion of population, those who are hypertensive, undergo treatment and are aware and under control. Of 28.5% with raised blood pressure, only 6.5% had their blood pressures under control. Whereas those with raised blood glucose of 9%, 11.8% had their blood glucose under control. So we see that there are huge challenges which we have to overcome. This is another main problem of a lot of respiratory diseases and cardiovascular diseases, use of solid fuels. But now we are seeing this will decline with a lot of government interventions to promote healthy fuels and usage over there. The National Cancer Registry Program Report 2020 has shown us the burden of cancers that will happen. So in 2020, we had 13.9 lakh new cases of cancer, whereas in 2025, if things do not improve, we do expect more than 50 lakh cancers, new cancers per year. And one can see them as differentiated by tobacco-related cancers, gastrointestinal, uterus, breast, and other sites of cancer. So this is a major burden which the country is facing and will continue to face unless we don't act. And there has been a tremendous amount of thrust being given by government, different ministries, different departments and sectors over the last 1.5 decades. And these are some of the reports which bring out guidelines. These are the reports which are monitoring them. And we are very much familiar with the Eat Right India movement, the Fit India movement. There is a whole program around national program on non-communicable diseases. We are trying to work and achieve universal health coverage, and Ayushman Bharat PMJY scheme is playing a tremendous amount of role and has a potential so that we see a new India at the 75 years of independence. ICMR and we all pledge that we will continue to do the right amount and right type of research which will be required to fill these knowledge gaps, to translate some of these research findings into action, and to provide a lot of succor to our population in the area of non-communicable diseases and related events happening. So thank you all very much. And I would like to take this opportunity to again thank you for being here with us and also understanding that where we need to act. And you will hear in the future, in the coming up panelist talk, what solutions they will provide. Thank you. Back to you, Dr. Sukanya.
Thank you, Dr. Mathur. So your talk explained to us about all the evidence and how we need to focus towards the NCD prevention and control. Now, of all the monitoring indicators which you showed, one indicator very distinctly stands apart, and this is about diabetes and obesity. And it says, halt the rise in diabetes and obesity. And this literally means a 0% increase in diabetes in our country. And what does that mean to individuals, communities? And to explain this on the interplay of the NCD risk factors and the management of diabetes mellitus, we are very fortunate to have with us Padma Shri Dr. Mohan, Chairman and Chief Diabetologist of Dr. Mohan's Diabetes Specialty Center and the Director of Madras Diabetes Research Foundation. He's a researcher par excellence and exemplary teacher. He has close to 1,500 publications. He's a key member and advisor of many committees in India and internationally. I could continue to share his achievements, and I would not do any justice. So it's my great privilege to invite you and request you to talk about the lessons for life, about the interplay of risk factors and how do we manage diabetes mellitus. I invite you, sir, and over to you.
Thank you, Dr. Sukanya. I hope my slides are visible. Is it visible, Sukanya?
Not yet. Yes, sir. Yeah, please.
It's visible, no? Okay.
Yes, please go ahead.
So thank you, Dr. Sukanya, for those kind words. I'd like to thank Dr. Prashant Mathur for inviting me for this very important meeting webinar on NCDs. As we all know, and as Dr. Prashant Mathur showed, NCDs are the major cause of death in India. 20 years ago, it would have been different because communicable diseases were the major cause of death. But today, the non-communicable diseases, or NCDs, are the major cause of morbidity and mortality in India. And I wish to congratulate Dr. Mathur, Dr. Sukanya, and all those who are involved in NCDIR. We just saw that excellent report of the NCD National Survey, which was presented. And all the details regarding hypertension, tobacco, raised blood sugar, and so on. Very, very important national data, which this institute has been collecting. So congratulations to Dr. Mathur and his team. I'm going to talk about the interplay of lifestyle risk factors and management of diabetes, lessons for life, after again formally thanking Dr. Mathur and Dr. Sukanya and the organizing committee of this meeting. So my job is actually easy because if you take all NCDs, if you take cancer, obesity, about which Dr. Govil will be talking after me, obesity, dyslipidemia, heart disease, stroke, hypertension, mental disorders, and COPD, you can actually put diabetes in the center. And the reason I put diabetes in the center, of course, is number one, because I'm a diabetologist and I have a bias towards it, but also because I think it's one of the easiest to measure. Suppose you want to measure whether cancers are increasing in India or not. It's a formidable task. How many types of cancers are there? Which one are you talking about? How do you measure their prevalence? And so only through registries and so on, you can do it. It's not at all easy to measure cancer. Hypertension, little more easier because all you need is a blood pressure unit. But diabetes, so simple, even with the glucometer, you can measure that. And therefore, and I do not know of any condition or any state or any place where the diabetes is increasing, but the rest of the NCDs are decreasing. So I would take diabetes prevalence in a community as a rough indicator. It may not be actually true for everything. COPD may not be totally related to that, but roughly, if you take diabetes as an indicator, if that is rising, you can safely assume that obesity, dyslipidemia, hypertension, heart disease, stroke, cancer, and some extent mental illness also is increasing in the community. Now, is that true in India that there is an increase? Of course, it is true. And these are data which I'm showing you from 1971 to 2015 in India. Various studies, including the first multi-center ICMR study, which took 6 cities and 6 villages in India. And as early as 1972, almost 50 years ago, showed that 2% of the adult population in urban areas had diabetes and 1% of the rural areas. Over the years, you can see 1984, 1990, 2000, as you go on, you'll find that the prevalence of diabetes is actually increasing. Not even in one study has the prevalence decreased, but it's actually increasing. And so also in rural areas. So the latest study, which we published from the CAR study, the Center for the Cardiovascular Risk Reduction study, which Dr. Nikhil Tanner and I take up. This is an NIH-funded study where Chennai and Delhi has been studied. The prevalence has now gone to 22% in 23% in Chennai, about 25% in Delhi. Compare this with 2%, and over a 40-year period, there's a 10-fold increase in the prevalence of diabetes. Rural areas, again a 10-fold increase, 1.5% increasing to 16%. So while rural areas are a little behind the urban areas, the population of the rural areas is so huge that any increase in the rural prevalence actually translates to many more millions of people with diabetes than the increase in urban areas. And we have to keep that in mind. However, these are all scattered studies. As you can see, Chennai studied, Ernakulam, Kerala, coastal Karnataka, Tenali, Delhi, and so on. This is not, except for this multi-center study, again, that was only in 6 cities and 6 villages. It did not study the whole country. If you look at this study, the National Urban Diabetes Study, it studied only the metros in India. It didn't look at the smaller cities, didn't look at villages, and so on. And therefore, the ICMR India Diabetes Study was taken up. This is, I would submit, the largest epidemiological study on diabetes ever done in the world, with a sample size of 124,000 people, representative of India's 1.366 billion, with every state in India being sampled, urban, rural, following the exact demography, the exact population distribution as used in other national surveys. This is indeed a treasure house of data, particularly on diabetes, but also on the other NCDs. For example, this paper published in Lancet Diabetes in 2017 reported on the prevalence of diabetes and pre-diabetes in 15 states of India. I'm happy to tell you that you now completed the entire country except Jammu and Kashmir, where there are some sensitivities, and a few places like Andaman and Nicobar Islands and Lakshadweep and so on, which actually has been sanctioned, and we are now going to do that as well. But the entire country has now been completed. When we finished these 15 states, we published our data, and you can see that the prevalence varies drastically, which is the reason why we did this study. You can see India is so heterogeneous. The lowest prevalence at that time being in Bihar, going up to at 4.3, going up to 13.6 in the Union Territory of Chandigarh. We have not published the next 15 states, but I can tell you those figures are startling compared to this, because 10 years has meanwhile passed, and 10 years is a long time for India for the diabetes prevalence to increase. The NCDs are increasing very, very rapidly. For example, in the last 3 states that we have done, Goa and in Kerala and Puducherry, for example, the prevalence rates are in excess of 20%. So we have the whole state. We're not talking about a city here. We talked about Chennai and Delhi having, only cities having 20%. Now the whole state of Kerala, the whole Goa and whole Puducherry, the prevalence rates are 24%, 25%. So we are very rapidly progressing as far as diabetes is concerned. The other thing which is shown here is the blue one. And this shows the GDP of the state, how rich a state or how affluent a state is, the GDP per capita. And you can see the lower the GDP, the lower the diabetes prevalence. And the higher the GDP, the higher is the diabetes prevalence. So this is one of the price we seem to be paying for affluence. As you get affluent, you get more obese, you get more mechanized, more stress, less physically active, eat richer food, and then pay the price of not only diabetes, but also hypertension and the other NCDs as well. So that's what this slide is trying to show, the dramatic change in 50, 60 years which has occurred in India. Earlier, people used to carry loads of weight on their head. Now, the only thing they carry is a cell phone, nothing else they carry. From the children who used to play in my days, we used to play in the fields like this. Today, nobody goes to the fields. What they're doing is playing computer games. That's the best they can do. Safety reasons, other reasons, stress of studies, so many things, you can explain it. The life has changed so much. We used to eat frugal meals when we were younger. Today, what we eat is junk foods. Most of the people. And why? Because these are people working in a BPO, in a call center, and other places where they're working to American timings. They, of course, get paid American salaries. So they get paid in dollars, and therefore they're making a lot of money. But they're working at midnight, 1 a.m., 2 a.m., and so on, when the rest of the people are sleeping. And this affects their sleep cycle, their circadian rhythm, which I'm not even going to go into. But the 3 main risk factors because of this rapid transition which has occurred is, number 1 is increased calories. The glycemic load has gone up. The amount of carbohydrate we eat, the amount of food we eat, calories, all have gone up. Number 2, there's a marked decrease in physical activity, which we also saw in the earlier slide, which Dr. Mathur presented. And of course, urbanization. He talked in passing about the pollution and other things, which are not very well studied, but definitely there's a component. And I don't have enough data, so I'm not going to present about those. But I'm going to focus on the 2 low-hanging fruit, if you can call it that way, the increased glycemic load and the decreased physical activity. This is one of our early studies, which we published from the CURE study. The CURE study is a Chennai urban rural epidemiological study, 26,000 people, representative of Chennai. Before we took up whole of India, we took up whole of Chennai. And there, in a cross-sectional manner, we were able to show, we divided Chennai. Chennai, as you know, is a rice-eating place, as is Bangalore or Karnataka or Kerala or Andhra Pradesh for that matter, and or for Orissa or Bengal. So if you take Chennai city and divide the population into 4 quartiles, the first quartile, the least amount of carbohydrate, in this case rice, it's about 200 grams of rice, which is huge even for the first quartile. And then as you go on to the fourth quartile, 400 grams of rice. See what happens to the diabetes prevalence. This is a cross-sectional study. If you take the first quartile as odds ratio of 1, it goes up 4 times. By the time your rice intake goes up from 200 grams to 400 grams, your diabetes prevalence has gone up 4 times. So imagine if this is 6% prevalence, that is 24% prevalence. So it's not a small increase, but it's a huge increase. You may say, well, it may not be due to rice, it may be due to obesity. It may be due to decreased physical activity. That's what we've corrected in the adjusted model shown here. We've corrected for family history, for BMI, for gender, cigarette smoking, physical activity, income. We've corrected for almost everything we can. And yet this 4-fold increase is due to the rice intake. So this is hypothesis generating because you can't really prove from a cross-sectional study. It could be that these people have something else which is producing diabetes. Point well taken. But this is one of the first studies to show that. To really prove it, you need a longitudinal study. You have to follow up people for 10, 15 years, getting their baseline diet, and then seeing how many people develop diabetes. Now, if you look at it in another way, in the same cure study, we also showed that not only the carbohydrate increase in carbohydrate increases diabetes, the glycemic index also increases. Your glycemic index goes up, your diabetes goes up. Your glycemic load, as it goes up, that also increases the diabetes. And guess what? If you have more fiber, your diabetes goes down. So just now, Dr. Mathur talked about fiber. So as you take more and more fiber and make your diet healthier, your diabetes goes down. So there is a lot of evidence here telling you that it's not just circumstantial or a statistical artifact. This is probably true, but it still has the limitations of a cross-sectional study. I was very lucky because I am also part of this very large study with Dr. Salim Yusuf called as the PURE study. The PURE study, if you thought INDIAB was big, PURE is huge. PURE study currently has 225,000 participants. The length of the study is now coming up to almost 20 years now, 20 years prospective follow-up of these people. 25 countries across 5 continents are involved in this. Almost 5 continents, only Australia we have not included. All the other continents are included. And the study started in India. It actually started in Bangalore, in St. John's. And we were the next to start in Chennai. And then one by one, we had 5 centers in India, and then it went outside India and to Canada and went on and on and on. We're still recruiting and we're still including. So this is the world's largest epidemiological study ever in anything. Okay. So I was part of the RICE study because Bhavdarini, my student who worked with me here, later joined Dr. Salim Yusuf. And together we worked on this to look at incident diabetes and white rice intake. Look at the number of people, 132,000 people in 21 countries, followed for minimum of 15 years. None of them had diabetes at the start. And then we divided the population based on the rice intake and saw how many developed diabetes over a 15-year period. You can see that in South Asia, where rice is consumed, India and Bangladesh being the most important place, the hazard ratio is 1.61, which means there's a 61% increase in the risk of new onset type 2 diabetes, depending on whether you take rice or not. In China, it used to be very strongly associated with rice, but China has started cutting down on its rice intake. They started increasing their protein intake, which compares with the number of medals we win in the Olympic Games, for example. Still, there is a small risk. And the rest of the world also there is a risk. And if you put it all together, it is still statistically significant. But South Asia stands out as the place where the highest rice consumption and the highest risk for type 2 diabetes with the rice. We also try to see in this, what if you're physically active and then you still took rice? You can see it's coming down. In South Asia itself, from 1.5, it comes down to 1.16 in those who are physically active, telling you that even if you take rice, if you're physically active, your diabetes is less, which explains why. But often I'm asked, in 1970s, you showed only 2% diabetes. Why is that? They were eating rice at that time. 2 reasons. Number one, they were more physically active. And number 2 is that the type of rice was very different. It was hand pounded rice at that time, not the white polished rice, almost like glucose, which we are taking now. So we published the study and it became an instant hit now, quoted all over, that the higher consumption of white rice associated increased risk of incident diabetes, the strongest association being observed in South Asia. What about physical activity? This is one of our earliest studies, again from CURES, where we looked at physical activity as an independent risk factor for type 2 diabetes. Now, this is after correcting for rice intake. Okay. So if you see in Chennai, where people are, the people who are doing heavy activity, the few who are doing physical activity, heavy physical activity, the prevalence was 5%. Whereas in the light physical activity, already at that time in 2005, it was 17%. So you can see almost a tripling of the risk factor independently due to physical inactivity. So now we have two risk factors, rice intake or carbohydrate intake excess, as well as physical inactivity. So we put this all together and we wrote a paper. Dr. Anjana wrote this paper and asked over a 10-year follow-up study. We again had incident data. After the follow-up, after the cross-sectional data, we had incident data. We looked at those who developed, like in Cure, but much smaller study from Cures. And we asked the question, how many people develop diabetes and how much of this can be explained by some of the modifiable risk factors. And what we found was in this model that we followed, 10-year follow-up, where we calculated the partial population at attributable risk factor. So if you just take diet and physical activity, unhealthy diet, too much of carbs, and physical activity, it explained 52% of the entire new onset diabetes. So half of the diabetes, the new case which are coming, can be explained just by diet and physical activity. If you add BMI, it goes up to 62%. If you add abdominal obesity, which Dr. Prashant Mathur showed, it goes up to 70%. 70% can be explained just by your waist as well as by the diet and physical and unhealthy diet and physical activity. And of course, if you add hypertriglyceridemia and low HDL, it goes to 80%. The remaining 20% is probably genetic. So you can, at least by diet and exercise, half of the diabetes can be prevented. Now, can you really do this? Or is it just a mathematical, statistical thing and you really can't? Because we are talking about zero increase in incidence of diabetes, as Dr. Sukanya just said. So I'm going to share with you two examples before I stop. The first is prevention of diabetes, a success story from Chennai. And I'd like to talk about this study. This is a real world experiment that we did. Now, what happened was before we did Cures, we did the first epidemiological study, a small study, just to get the feel of epidemiology. This is called as CUPS, the Chennai Urban Population Study. So we took a middle income group in Chennai, in Tirumangalam, in Asiad Colony, and then we took a low income slum in T Nagar, the Bharati Nagar slum. And we compared these two. The idea was that our hypothesis was, although there was no evidence at that time for an intra-urban study, we said these two, which are just 5 miles apart, we'll have higher diabetes here, and we expected almost zero diabetes in the low income group. Why? Because they walk more, they're poorer, they're thinner, they have all the things to protect them. Whereas these people have cars, their physical activity is less, they eat more, they're richer, they're more obese, and so on. When we got the answers, it was not a big surprise actually, that the middle income group had 12.4% at that time. This is in 2000, 20 years ago. Okay, 12.4%. Whereas in the low income group, we expected near zero, it was actually 6.5%. So it is quite high, but about half of what the middle income group had. We went to both the colonies, but the low income group was not interested. They had alcohol problem, they had diarrhea, they had tuberculosis, they had so many other problems, poverty. So telling them to prevent diabetes was not right 20, 25 years ago when we did that. Whereas the middle income group, very receptive. They said, tell us what will happen. So we said, you know what, diabetes is rising so rapidly from 2% in 1972, it's come to 12% now in your case. It's going to go to 20%. I just made up a number and said, it's going to go to 20, 25%, and therefore then they said, what can we do? We said, you have to prevent it. And it's eminently preventable by diet and exercise. The proof came later, but we said, let's prevent it. Let's try to prevent it. So they said, how do we prevent it? We said, why don't you increase your exercise? They said, we can't increase our exercise. The road is not safe. We don't have a place to walk. And, the lorry will hit us, or the dog will bite us, or chain snatchers will come in the morning. So we don't have a place to walk. Just at that time, we found, this is the Asiad Colony, just next to them was an open plot of land. So when we were talking to them, we said, what are you going to do with that open plot of land? Whom does it belong to? Oh, it belongs to us only. They said, what are you going to do? Oh, we're going to build the next colony here. So we said, why do you want to build another colony? Why don't you build a park? They said, how will you build a park? We said, you go to the government, ask them, they'll build a park for you. They went to the government said, no, we don't have money. So I said, why do you need the government? You don't need the government. You can build the park. Come on, you raise the money. We'll get some donation, something. Let it become history that, public built a park, So this became the first park probably in India, definitely in South, definitely in Chennai, which is built by the people themselves. They built the park. And since they built it with a lot of care. They had music in the evening and they had walking track. Children could play. They look after it now. For the last 15 years, 20 years, they're looking after it. It's one of the best maintained parks because it's privately maintained by the people. Okay. Now, why did we do all this? We are not social workers just to build a park. Our idea was to prevent NCDs, to prevent diabetes. So the first thing that we did was, are people using the park? So after 4 or 5 years, we went back. Initially, we had taken the survey, only 13% of people were walking, but that's all could walk. After the park came, this increased to 52%, which is a 277% increase. You may say, why only 52%? Well, many are old people, they have joint problems, some are just, impossible to change. Despite that, from 13 to 52% in a colony, and this is not an intervention, we're not paying them or something. This is naturally what happened. Are they doing it or not? 52%, half of them, you give them a opportunity, they're all increasing their activity. Now, meanwhile, as we predicted, the diabetes prevalence is increasing in Chennai. Okay. Now it had reached somewhere here, around 18%. Remember, it was 14% something, 12% when we went earlier. Now it's already reached 18%. We went to some colonies near Asiad colony. There it had already crossed 20%. So we said, all right, if we go back now to Asiad colony and we find it is lower in that same socioeconomic group, it must be due to the walking. It's a very bad way of doing research, but this is a real world experience. It's not a randomized clinical trial. So we went back. Remember, the original figure was 12.4%. We were very happy when it was only 15%. So we said, everywhere else 20%, 22%, Asiad colony is only 15%. This must be due to the diet. Of course, we also had other data. We saw that the waist had not gone up that much. Their blood pressures had not gone up. They were eating healthy. They were doing exercise. So this is a real life experiment, which actually got published. But the bad news also came. Remember the other colony which we left off, where we said nothing to be done and they were not interested also. Remember, the prevalence is 6%. We said, now we have to go back and see there also what happened. Maybe it's gone up there also. We thought, some 8%, 9%. We were shocked when we found that in that colony where there was virtually no diabetes, it's now become equal to the middle income group. Okay. Now there is a fallacy here. These people have not done intervention. These people have done intervention. But you can see that by doing intervention, they've reduced it to the level of the lower income group. So the title of this paper was Convergence of Prevalence Rates of Diabetes in the Middle Income Group and Low Income Group. Later on, we found in India that the poor people have now actually more diabetes than the middle, because they are going to gyms, they are exercising, they know about it. Whereas the poor people really don't know anything about diabetes and they're not willing to listen also. So their diabetes is now increasing much more. A complete reversal has happened. This is what we call as an example of translational research through community empowerment. I'm showing this because when I was asked to talk, the instruction given by Suganya and Dr. Mathur was include some examples where you have been able to change the behavior of people. And I think this is a very good example. And WHO has covered this extensively in their chronic diseases manuals all over the world as an experiment done by people for people, which has worked. Now, I just want to show you one more real RCT. So based on this, we said, now let's do an RCT. Let's take people with pre-diabetes and give them a program now and see whether we can prevent it. This is funded through the International Diabetes Federation. Dr. Venkat Narayan from Emory University helped us. 3 people here got a PhD out of this. 2 from US who came here to do PhD. And of course, Ranjini and her colleagues who also did their PhD here. So what did we do? We took 600 people with pre-diabetes. One is a control group. We just told them, do diet, do exercise, do this, and gave them some tips and so on, and left it like that. The other group, we called them and we gave them 24 classes teaching them how to do physical activity, and then made them go back to the community and do it, change their diet, reduce their carbohydrate intake, increase their vegetable intake, increase their fruit intake, increase their fiber intake. We did all that. And what did we find? What we found was that if you look at pre-diabetes, there are 2 types of pre-diabetes. In the whole world, all studies on pre-diabetes are done only in IGT, impaired glucose tolerance. There is one more type of pre-diabetes called IFG, impaired fasting glucose. They had never included people with IFG in any trial in the world till this study was done. So what we found was, if you had IGT, 36% reduction in the incidence of diabetes. which is very good, more than 1/3 getting reduced from prevented from diabetes. If you had IGT plus IFG, it was 36%. If you had IGT alone, it was 31%. But we are in for a shock. If you had the other type of pre-diabetes, where the 2 hour is normal, but the fasting is high, these are people who are more of insulin deficiency. Even after the intervention, only 12% could be prevented. So we learned something, that for all pre-diabetics, it's not the same prevention. We'll have to find something different for these people with IFG. And now we are working on it, how to improve their beta cell function. That need a different study altogether. So what we concluded was, and we also gave them metformin. If it didn't work after 6 months, then we gave them metformin. So stepwise diabetes prevention can effectively reduce diabetes incidence by 1/3 in community settings. However, people with IFG need different interventions. The first time in the world that we are able to show this. So therefore, ladies and gentlemen, I'd like to conclude by saying that the diabetes epidemic in India is still spiraling upwards. Unhealthy diet and physical activity are the main factors contributing to the diabetes epidemic. The Asiad Colony success story shows that by lifestyle modification, the epidemic can be slowed down. And the DCLIP trial showed that diabetes is preventable in those with pre-diabetes. Just by doing structured physical education and dietary modification, you can actually prevent diabetes by 1/3. Imagine if you reduce diabetes by 1/3 in India, you'll probably prevent some 20-30 million people from getting diabetes at no big cost which is involved. And I think this will beautifully fit in with the Fit India and all the other programs that our Prime Minister announced and which Dr. Prashant Mathur talked about. So I'm going to stop here, thanking all of you, and we can take some questions later. You're muted, Sukanya.
I think okay. So that was an excellent talk. Thank you so much, sir. You know, diabetes is a complex disease, the way you kind of showed it in the center of all the NCDs, but you made it sound simple, you know, with your examples and interventions, and especially the community intervention trials and the Asiad Colony experience. I think it gives a lot of us, you know, there are about 150 people who have joined in through the Zoom and many more in the YouTube. The experience which you have shared has given us, many of us as individuals and as communities, that there could be a halt in the rise in diabetes. I request all of you to put in your questions in the Q&A box. We will take them up at the end of the webinar. Please do write your questions. You know, you've had 2 excellent presentations explaining the evidence on NCD risk factors and the wonderful work Dr. Mohan had shown about the rise in diabetes prevalence, the interlinking of risk factors, and what we can do as individuals and families and communities. Please put in your questions in the Q&A box. We look forward to your comments and suggestions and questions. We'll take them up at the end of the show. I now would take all of you to another different track. And this is about dealing with 2 very difficult risk factors, tobacco and alcohol. And today we have with us Dr. Dheeraj Katula. He's the Associate Professor of Psychiatry from Christian Medical College, Vellore. He is trained in psychiatry and also recently in addiction medicine from AIIMS, Delhi. He's worked in several hospitals in rural India. His interest areas is substance abuse disorders, behavioral habit disorders, obesity and ethics. And he will now explain how do we tackle tobacco and alcohol, what are its intersections with NCDs, and give us few examples, what we can do, what we can learn about tackling tobacco and alcohol. I invite you, Dr. Dheeraj, to share your slides and give your talk. Over to you.
Thank you, ma'am. Are the slides visible, ma'am?
Yes, they are visible. Please go ahead.
It's very difficult to speak after someone like Dr. Mohan, sir. My talk is actually directed towards the common people and not just academics. So we'll be looking at different ways of tackling tobacco and alcohol. First, I would like to cover the areas of harms related to alcohol and tobacco, and then briefly look at the extent of use in India, and then look at certain myths about addiction, and how do we tackle the problem in those who have not yet started the use, those who are currently addicted, and those who have not yet become addicted who are using, and also look at briefly some policy issues and the effect of COVID-19 on the use of these substances, and few take home points. Which one?
The slides have been unshared, Dr. Dheeraj. Can you put them back?
Ma'am, yes.
Can we share it from our side? Is that okay?
Yes, ma'am. Yes, ma'am.
Yeah, we'll do that. Give us a second.
And we finish with some take home points. Next slide, please. Yeah, if we look at the different harms caused by different substances, the harms caused to the person who is using the substance, and also harms caused to others because of the use of substance. Alcohol stops all substances. It's more than even heroin, crack cocaine, methamphetamine, and cocaine. And if you interestingly, the harm to others is the proportion is very high with the alcohol use. And of course, tobacco also comes a bit later. And in what ways does alcohol cause harm to the body? We'll see that in the next slide. We can see that because of the use of alcohol, the brain, there is the death of certain neurons, and there is shrinkage of brain in different areas. Due to intoxication, there is the person may forget what has happened during the bout of his drinking. There are behavioral changes due to alcohol, like suspiciousness, violence. Of course, it leads to addiction. Also, there's increase in cancers in the oropharynx, esophagus, stomach, etc. There's cardiomyopathy, weakening of the heart muscles, liver damage causing later cirrhosis, jaundice, and death, pancreatitis. A few bouts of pancreatitis, after a few bouts of pancreatitis, people develop diabetes, and we heard about what all happens in the previous session. And gastrointestinal problems, sexual dysfunction, infertility, and neuropathies which cause tingling and burning in the feet. So overall, a lot of areas of the human body are affected because of alcohol use and due to chronic alcohol use. Now let's look at what happens with tobacco. If we see the main killers that exist, ischemic heart disease like heart attack, strokes, breathing difficulties, COPD, respiratory tract infections, cancers involving the upper respiratory tract. All these, there is a significant proportion which is actually contributed by tobacco. If you see, tobacco use is a big killer, one of the top killers in the world. Next slide, please. And what are the problems that tobacco causes? We can see multiple cancers, like from oropharynx, larynx, esophagus, trachea, bronchus, lungs, blood cancers, stomach, liver, pancreas. Most areas it causes cancers, and also other chronic diseases like it also has risks of developing stroke, pulmonary disease, etc. And if you see if 100 people start smoked one cigarette, if 100 people smoke one cigarette, 32% of them, 32 among them are likely to become dependent or addicted to it. And that number is so high, even for ganja cigarette, it's going to be about 9%. But for the normal regular cigarette, it is 32%. And that number is about 15 for alcohol. So if 8 people drink, one person is going to become dependent in a youth group. So we have to be very, though we take alcohol and cigarette lightly because they are legal substances, they are very, very harmful. Next slide, please. So how widespread is the use? Prashant sir's presentation had his data from 2016. This 2019 data is very close to the data that was presented. About 15% of the people in India drink alcohol. What is important is that means 85% of the people are not consuming alcohol, and that is the norm. Not consuming alcohol is the norm. 15% consume, and among them 5% develop problematic use, and about 3% become addicted to alcohol. And what about tobacco? About 50% of them of the men consume alcohol in that study. About a fourth of them are overall using tobacco of both smokeless and smoking forms of tobacco. And if we ask 50% of them want to quit, and on asking if healthcare workers who provide services to them have talked about about quitting, 50% of them, the smokers, reported that we tell them that it's good to quit, and only 30% of the people who use smokeless tobacco have been advised to quit, which just shows that our healthcare providers should be a little more proactive in tobacco cessation. And regarding the exposure to secondhand smoke, 40% of the people are exposed in homes, and 30% of them are exposed in workplaces. The good thing is that these have been coming down in the past decade, but still they are quite high. Next slide, please. And what are the certain myths about addiction? Like we all people feel that using tobacco and alcohol is a choice, so addiction is the person's fault. But the truth is, in the beginning, when a person chooses to use substance, that's his choice. But after it becomes regular use and he becomes addicted, the dependence sets in, it's no more a choice. It's like a disease. And therefore, when we say, okay, with willpower, one should be able to stop anything, it's not going to work. It is like a disease, and like diabetes, sugars are not going to go down by themselves. Like, you have to work on it. So, and take medical treatment if necessary. So people with addiction are morally bad and so deserve punishment. It's understandable. People may fight with the wife or demand money and do some criminal acts to get some money to procure their substances. But many of them, when treated, they give up those behaviors. So it's not that they are intrinsically bad, but it's the addiction which makes them do bad acts. And also people think that if they are having a stable life or family, a stable family life or a job, they will not be addicted. But not so. Many times addiction can happen after patients are exposed to certain substances, not alcohol and tobacco, but other substances are exposed. They get exposed by when doctors give them and they get addicted. So it's not like that also. Some people think that people have to suffer a lot and hit a rock bottom before they can get help, but not necessarily. When we offer help, people might want to choose to get treated even before they hit a rock bottom. And going for treatment doesn't mean that it will fix everything. The relapse is a norm. People would quit and then after some time try again and slip and fall into a relapse and then try again. So this is the cycle that would be, because addiction is a chronic relapsing disease. Therefore, relapse is a norm, and just because somebody relapsed doesn't mean treatment had failed. Next slide, please. So how do we tackle this problem? So first, there's a section of people who are not using substances, not smoking, not drinking alcohol. There are some who started using, but they are not having addiction yet. They have not developed it. And those who currently have used and they have now developed substance use, the approaches would be slightly different for each of these. Next slide, please. So how do we prevent? To there should be certain universal preventive strategies which should apply to all people, all population. We should focus on social norms and the climate rather than persuasion for people to not indulge in it. So, for example, the understanding that 85% of the people of our country are not drinking alcohol is a message that alcohol doesn't have to be served in every party or every social function, because only 15% drink. So this gives the strength for people when they're in a situation where they're offered, they'll be able to say, I don't have to choose to drink because it's only a minority who choose to drink. I can as well not drink. So that we give that option when we stress on the social norm. And persuasion, giving gyan doesn't really work with things that give pleasure. Also regulating the public regulation and market interventions to create protective and positive school and family climate. And this definitely works through proper social policy and legal efforts, like increasing the age for purchase, stronger enforcement of underage purchase laws, increasing the price of substance through taxation, and limiting the sale hours, and zero tolerance for people who drink and drive. Next slide, please. And for those at risk, that is those who started using but they have not yet become addicted. So there should be changes in access within the environment. Like if an area is having a drug problem, then police should look into those areas, and having no smoking zones, like you're cutting down the environmental access to smoke. So like that. And promoting development of personal and social skills, and these apply a lot to people who are in the younger age group, adolescents or young adults, like helping them to develop goals and alternatives, promoting positive relationships in their family, developing positive schools, enhancing motivation to avoid substance use, and addressing social influences and providing social support. Next slide, please. So in primary school, the target should be to improve academics, social and emotional learning, to address risk factors of drug abuse like early aggression, academic failure, and school dropout. So many children who have show this violence in school, probably started smoking or drinking once in a while, they get suspended in school. So when I see them, I actually take some effort to call up the school principal and tell them that the best shot this child has in life is to be in school. If he were to drop out, and a lot of hope gets lost, because he will fall into a deviant peer group. And therefore, after listening to all that, many principals actually give a chance to the child to stay back in school by giving a strict warning, etc. So dealing with aggression, academic failure. So that's why this education, why are they actually becoming bully? Why are they aggressing? Because they're not able to study well. And the only way he would feel stronger is actually to by showing physical strength or doing adult activity like smoking or drinking. So addressing these other things which are not looking as if they're relevant relevant for substance use can make a big difference in the initiation of substance use. So education should focus on skills for self-control, emotional awareness, communication, problem solving, academic support, especially reading skills. Next slide, please. So in the older school age children, again, academic and social competence should be increased with proper study habits, academic support, communication, peer relationships, self-efficacy and assertiveness, drug resistance skills, ability to say no when substances are offered, reinforcement of anti-drug attitude, strengthening of personal commitments against the, like signing a bond, like a slip telling I will not take substances, teacher training in which teachers reward good behaviors in the classroom. So these things would go a long way in giving self-esteem to the child and would not push him towards finding happiness in substances. Next slide. So after all this, there is also a chance that a person would start using and would increase the use over time and become addicted to the substances. So at that stage, we have to actively treat. This person has no more control over cutting down on the substance. So at this stage, even if he wants to quit, his body would go through certain changes. For example, in alcohol, the person may develop tremors, he may not be able to sleep, feel very restless, feel sweaty and all that. So in that distress, he would end up going back to the substance because that would relieve all his problems temporarily. So at this stage, we need to do medical management by giving appropriate medications to control the withdrawal. But the withdrawal lasts for a finite period. And after which, but still the craving would stay, like he would have repeated urges to consume the substance and procure the substance. So there are methods, both psychologically and also by use of medication, we can control craving. So that needs to be done. Many of the people who have reached the level of addiction, they may develop some psychiatric and medical complications, and those need to be addressed. And of course, there are certain specific medications for different substances that either remove the high when the person takes the substance, or create an aversive reaction when the person takes substance. So sometimes some family members take those things and mix them in the food without the person's knowledge, thinking that that aversive reaction will help him keep away from it. But that could be very risky. It's not ethical to do. It can also cause death in very rare instances. So that's not something that we recommend. We always engage the patient, and with their voluntary consent only, we give that kind of medication. And if patients are not really interested, but if they do make a contact with the healthcare providers, we try to enhance their motivation to change. And if they do come to the point in which they're abstinent, then we would focus on strategies to prevent relapse. That is, it's possible that a person may try out and have a lapse, that is restarting the substance. But relapse is something like using the substance in the previous pattern that he had been using. And therefore, there are strategies to help him and use that particular event as a learning opportunity. So we do these kind of things. Next slide, please. So this, we might all substance, alcohol, tobacco have been there for forever. Man has consumed substances for pleasure for millennia. So we cannot just expect this to go away, and people might just want to continue. And therefore, at that time, we would be stuck if we say abstinence is the only idea that we have, or the end point we have. At that time, we would accept, okay, this guy is going to do it, but then we would try to decrease the negative consequences in his life or for the people around him. So in alcohol, it would be something like, okay, you're going to drink, but you cannot drink and drive. There are if he's going to drink, if he gets violent, it's going to cause harm to others. So bars can have some special glassware which, when shattered, cannot become a weapon, but it would just break into small pieces. Or have very padded furniture. Use drivers in the bars to drive people who are intoxicated and who are under the influence of alcohol to drive back home and come back. Interventions like that. Have low alcohol percentage beverages, have no happy hours as policy, and increase the cost of alcoholic drinks with higher percentage of alcohol. For tobacco, it is considered that non-combustible forms of tobacco could be better because combustible forms of tobacco could create more carcinogenic chemicals. But the evidence is not very clear, and we can't say that very sure. So it's still debatable that harm reduction can exist. So tobacco, a strong anti-tobacco cessation model should be the way to go. Next slide, please. Certain policy issues, like we have to see that, continue to monitor how much alcohol is being consumed, where it is being consumed, what is the percentage of people who are consuming. Those things need to be monitored, and also our prevention policies need to be monitored. we have to protect people from tobacco smoke and drink driving. So laws and the implementation of the laws should be strict. We should not see people who are using these as bad people or criminals with regards to other drugs, but we should offer them help. That would be an important part of the policy. Warning the general public about dangers, enforce bans about advertising, promotion, or sponsorship of these tobacco and alcohol companies. Raise taxes. As prices go up, demand would fall, and also continue mass media campaigns. So the effect of COVID-19, of course, during lockdowns, people were not able to get alcohol, and people who were dependent, many of them developed complications, and that became a problem. So many of the addiction facilities were open and were trying to help those with alcohol related problems. But there was a sudden black market of alcohol products, and people had to resort to that. And also there were some misconceptions about alcohol use, thinking that, oh, we are using alcohol rub as a disinfectant, so drinking alcohol could probably protect us from COVID. So those are all false. And alcohol, because of lockdown, boredom, lack of employment, loss of money, stress, alcohol use led to a lot of domestic violence and mental health issues. And so that also needs to be seen. And smokers, the WHO Director General has said that the smokers have 50% higher risk of developing severe disease and death from COVID-19. So it's the best time to quit to lower their risk during the pandemic. Next slide, please. So as we finish, just few take-home points. If you don't take any substances, don't start. And if you are already taking less is good. Decrease the use. And if you're not able to decrease, there's a possibility that there's some addiction. You should seek some professional help. Also remember that starting to use substances is a choice, but addiction is not a choice. It is a disease. And substances have been used for millennia, so we just can't wish them away. So the approach that we should take is that of a public health approach. Well, how should policies be so that substance use is lesser, so that NCDs would be lesser, so that there is greater level of health for most people? Thank you.
Thank you, Dr. Dheeraj. That was a very interesting talk. You kind of laid down simple steps for many of us young physicians who have joined, to say, how do you approach, even in primary healthcare or secondary healthcare, many of the doctors do not have such skills to guide patients with tobacco and alcohol, addiction. So that was a very, illuminating talk for most of us. Please stay on to the webinar, and we hope to take few questions later. And we will now go on to the last speaker. Most important for all of us to learn is, how do you work with communities? Our three speakers spoke about the evidence, spoke about community interventions, about diseases, tackling risk factors, but then how do we work with individuals and communities? And with us today, we have a very resourceful person, Mrs. Jyotsna Govil. She's the chairperson of the Indian Cancer Society Delhi chapter. She's been associated with the Indian Cancer Society for a very long time in various positions and capacities, and comes with immense experience working with people, with communities. She's also part of the Healthy Alliance, which is the NCD Alliance initiative called Our Views, Our Voices initiative, and people living with NCDs. She's been a strong advocate for NCD prevention and control, and she's been guiding the Healthy India Alliance as a member of the governing board since its inception, particularly on work related to meaningful involvement of people living with NCDs. In Our Views and Our Voices initiative, she's participated in several community conversations. She's led the planning of the HIA regional consultations and provided inputs for the national advocacy agenda of people living with NCDs. So Mrs. Jyotsna is here to explain to us her experiences, her insights on how do we engage with communities on NCD prevention and control. I welcome you, ma'am, and invite you to give your talk.
Thank you very much, Sukanya. Can you hear me?
Yes, we can hear you. We are sharing your slides.
Great. So give me a moment. Just leave this for a moment. I'll be speaking more than using my slides. So I'm afraid you're going to have to bear with me. My subject was community engagement for NCD prevention and control. And the first, I think my entire talk is going to be a lot of questions for the audience, and I hope that they are thought-provoking. So can I have the next slide, please? Now, I know that Dr. Prashant and Dr. Mohan have given you beautiful slides on the incidence and on the magnitude of each disease. The reason I put this up is merely to emphasize the magnitude of the problem. Just look at the incidence. Everything is in millions of population. And I try to remember at all points during our work in the community that when we talk statistics, that statistics are people with the tears wiped away. You don't see their pain when you look at these statistics. You just look at numbers. And for us community workers, we have to see their pain if we are going to make any kind of effective intervention. Can I have the next slide, please? We can go on to the next one. The risk factors have been covered by all the erudite speakers before me, but I want to ask another question, and I'd like any of the participants to take this, that who is responsible for community engagement? Is it only the NGOs, or is it also the educators? Should we be involving teachers, professors, researchers in the entire process of getting the community involved in preventing these, recognizing first these risk factors and then preventing them? Let's start with diet. Our traditional Indian diet, as Dr. Mohan has shown already, was a basic of rice, roti, dal, vegetables, dahi. And it is only now, in the last 20 years, that we have this plethora of fast food restaurants. The entire pandemic has shown that home delivery of food has become more the accepted norm. Hardly anybody was cooking in their own homes during this period. And I think that at the end of the pandemic, hopefully soon, when the researchers start to get their numbers together, you're going to find that there are many more people with diabetes, many more people with obesity, many more people with cancer, many more people with all the NCDs, because nobody told the NCDs to stop because COVID was going on. People did not go to hospitals at the right time. They waited because they were afraid of catching an infection, or they waited because the clinics were not open. So in all, I think that with this unhealthy diet, with no place to go, being stuck with complete physical inactivity, there are going to be consequences which we will be paying in the future. Look at our environment. We haven't really paid sufficient attention to our environment. We accept a gray sky, a smoky sky, plenty of particulate matter coming down as the norm. We forgot what it was to see blue skies until the pandemic, when we suddenly became aware that yes, the skies could also be blue. Look at your workplace and look at your style of working. When you worked in an office, you were working at a proper desk, you were working with a proper chair, you were sitting upright, hopefully, you were traveling up and down to work. Now with work from home, you're slouching, you're in your bed, you don't even bother to get up and get dressed, excepting for the part of you that shows on the screen. And so the entire attitude is of not merely physical inactivity, but also a kind of mental shutting down. Stress and isolation have been a huge factor. They have contributed to the amount of depression and dementia. And please remember that when we talk of mental health, don't just confine yourselves to Alzheimer's and other dementias. A huge section of the population is depressed, and that depression causes them to go into unhealthy habits, whether it is eating wrong, whether it is smoking, drinking, drug abuse, and whatever else it is. There is no sense of community. I think the whole way of life earlier, when we were all there to support each other, when we met each other all the time, when we interacted with each other, gave us all a kind of mental stimulus that was invaluable. We are losing it. COVID is only one excuse, but as the years have progressed, neighbors don't know each other, they don't talk to each other, they don't go out together. It's a sad, sad situation. Have you got the pictures of those migrants rushing home? What were they looking for? They knew they had no jobs there, but they were looking for their families, their community, their connection. So I think that we underestimate the sense of community hugely when we ignore it. And then the commercial determinants of health, the commercial interests. What comes first? Is it necessary to have a balance sheet which is beautiful for all these companies which interfere with our living styles? Why should a tobacco company have this fat cat attitude? Why are they going into producing biscuits? Why are they going into running hotels? They know that at some time, God willing, that the laws on tobacco will get tighter and tighter, and they still want their profits. So while they go into all these other areas, they make sure that they keep their logo intact. So when a child is eating a biscuit bought by a fond mother, grandmother, father, whatever, and it has the same logo, when he sees it on a tobacco product or he sees it in other products, he feels it is safe enough to go into it. Look at the foods that we eat. The amount of salt and sugar that we unconsciously consume in all the packaged foods that are available. The amount of salt in the chips, the packet of chips, which children routinely take as their tiffin to schools, because it is much simpler for a mom to take out a packet of chips and hand it over in the morning when she's rushing off as well. Look at your noodles. I mean, when we talk about unhealthy food and when we ask for mothers at home to reduce the amount of maida that they use, they say, yes, we have reduced it. But what about noodles? It's Maggi noodles Zindabad. Without it, no home runs. And all of it is not just maida, because maida on its own cannot give you the taste you want. That has to have a certain quantity of fat in it, a certain amount of salt, a certain amount of sugar, and then it becomes the tasty noodles that the children and you love. So when we think about foods, it is not enough to say eat vegetables, eat dal. They do that, but they also are eating all these extras, which are contributing towards the unhealthy diet that we're looking at, to the wider and wider waistlines, to the obese children. In a country with so much malnutrition, I think it is, I don't know, I feel really sad when I see children so obese that they're unable to run. Is it any wonder that we do so badly in sports and so badly at big tournaments like the Olympics? We have to think about it. The next slide, please. This was an afterthought, but I really felt that it expresses what we all want in very simple terms. Dr. Mohan, not everybody builds parks, but everybody can walk. And look at the number of things that a simple walk, half an hour a day, can do to improve everyone's health. Not merely reducing the risk of heart disease, reducing weight, it reduces stress levels, it increases energy levels, it stops you from getting anxious to the point of mental disease, it increases the functioning of the lungs, and it affects every part of the body and helps people to find a solution. Next slide, please. Now, I've got a whole lot of questions here, but before that, I want to tell you a little bit about my area of work, which is in cancer. And we started off by recognizing that the conquest of cancer was by choice and not by chance. We had to make people aware that they were choosing a lifestyle, they were choosing a disease or a multiplicity of diseases by making the choices that they do. So when we talk awareness, we talk lifestyle. We've been talking lifestyle for a very long time, long before this Prime Minister and probably the one before him as well. The other thing that we realized was that disease does not start in a hospital and nor will it end in it. When we know that it does not start in a hospital and there are wonderful people like Dr. Mathur, like Dr. Mohan, who are talking prevention, but who speaks about the long-term side effects of all these diseases? You can cure cancer if it is caught in the very early stages, but you cannot cure diabetes. You can only manage it. You cannot cure heart disease. You can only manage it. You cannot cure asthma. You can only manage it. So who is thinking of the life of patients after the immediate emergency is over? In cancer, we see the effects because people come back to us over and over again. With breast cancer, we know that women have lost a breast. So our third adage is read my lips. See what the patient wants. What do they want to, want us to do that makes their life easier? I'll tell you about a small incident, which wasn't so small at the end of it. When we started our screening in Delhi, cancer screening in 1984, there were not many cancer hospitals in Delhi at all. Doctors were doing a tonsillectomy one moment and then carrying on to do a mastectomy the next. When we diagnosed a woman with breast cancer, she came into our office and thumped on the table and said, "Aapne to mere ghar mein aag laga di." So we said, "Why?" And she said, "You've told me that I've got cancer. Now tell me, where am I to go? I can't afford to go to Bombay. I can't afford to go to New York like some of the others are doing. Where do I go? It was a question that burned into our brains. And we had, at that time, our chairman was Mr. K.K. Mehta, who had the zeal to say we've got to address this issue as well. And from being a small NGO to then going on to build the Rajiv Gandhi Cancer Institute and Research Center in Delhi with 500 beds today, let me tell you, it was a long journey. It was a tough journey, but we addressed that woman's needs. Where do I go? And that is where we want to help people to go into a hospital where it is not a profit-making hospital. All the money that accrues there goes back into improving and increasing the scale of operations of that hospital. I tell this story because it sometimes saddens me to see hospitals become like an industry. There are wonderful doctors. I know a lot of them. I respect them greatly. But at the end of it, if all that matters is your bottom line, then I think that we have to start thinking again. There are new medicines coming out every day. Doctors keep on prescribing more and more costly medicines, even when they know that that patient does not have time to live. They're destroying not merely the patient, but the patient's family as well, and their trust in the medical profession as a whole. Is this community thinking? I think it is. Is there anyone listening to the survivors of disease? The survivors will tell you how a hospital should be run, what they found was lacking in the treatment they were getting. Why are survivors, people living with NCDs, caregivers, NGOs, always the last to speak in any meeting? Is it that they pull the whole meeting together? Or is it like in the good old or bad old days, depending on how you see it, when we had physical meetings, we would go into a room with our preparatory slides and everything and find we were only talking to ourselves. It is time for the whole medical community to work with survivors. We in the Indian Cancer Society in Delhi have a survivor group. It's called Cancer Sahyog. We walk together, Sahyogi hain hum, and we talk to the patients. We find out from them what they require. So we have a healing center, a breast rehab center that we call Prashanti, where people can come for breast prosthesis. The breast forms immediately post mastectomy, but proper silicone prosthesis, for which we've built a connection with the NHS nurses in the UK. We have talks about lymphedema, about arm care. We have pressure sleeves that give them relief immediately. We listen to all their other woes, how they are treated, how they are looked at, and we try that we have our counselors there, but the most effective counselors are the survivors, because a woman looks at another woman who has survived breast cancer and she says, oh, she's got her hair back, she's upright, she's full of zeal, she's doing everything. Now, if she can do it, I can do it too. So this is the way that we encourage the community to come back to a new normal. It'll never be the old normal again. You cannot forget the scar on your chest, but it is a new normal, a new way of living, and we teach them to face the world with a smile. We give them medical assistance while they need it for treatment, because everyone needs that little bit of help to keep going. But when medicines start to cost in hundreds of thousands of rupees for each vial, we have to tell them that I'm sorry, but we cannot help you. I think that I'm coming now to the end of what I wanted to say. I've talked about the cost of treatment. I've talked about patient care. I want you to think about one more thing. The whole subject of palliative care. There is a fair bit of confusion about palliative care. It's mixed up with end-of-life terminal care, which it is not. Palliation is giving comfort. And that is what doctors and nurses do at their best. They comfort even as they treat. So even if they can't cure, they at least care always. And that is something terribly important. End-of-life care is when organs are shutting down, when they're not able to, when the patient, the family, the doctors, everyone knows there's not much time left. What do you tell a patient at that point? You ask them to settle their affairs, to be at peace, so that they die in comfort, hopefully in their own homes, and always at peace with their loved ones. To prolong life as a clinical trial or something else is, in my mind, obscene. Mental health is my last subject, and which is why I've said make it a part of the conversation. We think it is shameful to admit to being depressed, to seeking help for it, and to try and do what we can to improve matters. My husband died of Alzheimer's dementia too. I know what it is like to look after a patient in those last days. And I really feel that unless we make this a part of a conversation where we recognize someone in need of help, somebody who is wandering, someone who's lost, we are losing a lot of great time. So Kanya asked me for some case studies. Can I have the next slide, Sukanya? I don't want to give you a long treatise on it. These are people whom we screened at our detection center and at our camps. And I just wanted to tell you about the different reactions of families towards them and how it affected their treatment and ultimate outcome. All of them survived, God bless them. The first was Hoshiari Devi. She was diagnosed with cervical cancer. There was great shame about cervical cancer, as if it was something that she had gone out looking for. She didn't want to live, she didn't want treatment. But it was her daughter who persuaded her, saying that, we want you, we need you, and here is someone who's coming out to help you with medical assistance. Come on, I will go with you every time. She would come to the hospital. Our volunteers were there with her all the time. She completed her treatment. She is well. She comes back for her yearly consultations, and we ensure that she does. The second was Kamlesh. She was the wife of a CRP Jawan. That man was so amazing. There are many men who abandon their wives when they have cancer. They say, we don't want that woman in our home. But here was this man who actively encouraged her to come for treatment. He would come in his uniform to the hospital so that she went in and came out of chemo or radiation therapy. He was there for her physically, visibly. And it made a huge difference to the outcome there as well. The third was the case of Bubbly. He's an elderly man now, but he's still Mr. Bubbly. he owned land in partnership with 2 or 3 other brothers. And frankly, we got the impression from talking to the brothers that they did not want him to survive. They thought he was on death's door. He had no wife, no children, no dependents. So that land would now be divided between 3 instead of 4. So they were dissuading him all the time about coming for treatment. And on the other hand was our volunteer who said, "You're mad. You've got everything going for you. Why are you giving up? And why are you handing over everything?" And he also came for treatment. He also recovered after treatment, went back to the family. We do our follow-up after a year, each time when they're due to come to the hospital. It's not very much, but it's what we can afford to do. That's where the survivors come in, because they know what it is like to go back and get their own screening done year after year. So they keep an eye on individual patients, and anyone who is diagnosed at our detection center or at our camps, we ensure that we make full payment for their treatment. So there is a sense of belonging with the ICS when we do that. Next, please. So this is what I want to really end with. We have to, you asked, how do we take information into the community? We need to integrate education. We need to integrate health, sanitation. How can you have health when there is no sanitation? In most villages, in a lot of small towns, we go there and it is disgusting. We walk through slush and mud. We see pigs and children playing together. It is not a pretty sight. But our sponsors and we work to find ourselves a decent place where they can come. Very often, we have had to take our jharus and remove all the cobwebs from the room that have been allotted to us in the so-called schools in UP. We have an outreach program in Vrindavan. We have an outreach program in Hilalpur, which is a new district. And the difference between the two is startling. Because in Vrindavan, there is no stationary NGO who takes care of that community in that area. Whereas in Nu, there is another NGO who is dedicated to that area and to making sure of the health of the people in that area. Clean environment is something that we need to think a lot about. I mean, we have a situation in a city like Bombay, where the sewage of the city flows into the sea. Now the sea can only take that much. And now the sea is returning the favor and sending all that sewage back on the beaches. Bombay's beaches used to be clean white sand. Today, they only have a whole lot of plastic bags, every kind of filth back on them. There are volunteers who are doing a cleanup job, but I'm talking to the engineers in the community. Can you not think of a way where we stop polluting our rivers, where we stop polluting the oceans with our filth? If we are talking NCDs or any kind of disease, that, to my mind, is the first step, that we learn personal hygiene and learn that we cannot continue to pollute our sacred rivers, the sea around us, with all our filth. The last slide, I think. No, sorry. I'm asking you to think of the treatment, the cost of treatment, keeping palliation as part of treatment to a state of terminal care. I'm asking you to think of the cost of treatment and of medicine as a mere industry. We have to think care, we have to think health if we are going to be talking about prevention in the community. And please keep talking about this. Keep telling people about it. It's only when the groundswell is strong that the people on the top listen. They will listen if there are enough voices that say enough, enough. Have I covered it now? Yes. I'm just giving you a few links. Everything that we develop at the Indian Cancer Society is given free to the community. So we've developed a course on cancer fundamentals. It is on the Swayam platform of the Government of India's HRD department. I've given you the link there. We have a simple mobile app called M-Shakti, which talks to women about the first stages of breast cancer and cervical cancer. It's free on Google Store, and it's made for Android phones because the women whom we want to reach are not the iOS variety. They are all people of the working class and who can look and listen to good doctors talk to them about their own health. And of course, our website. It's easy to remember us because our entire name is there, Indian Cancer Society Delhi.in. The same thing if you want to write to us, admin@indiancancersociety.in. Please connect with us. Let's keep this conversation going. Thank you all for your patience. Thank you.
Thank you, ma'am. Your talk kind of explained to us that individuals and families, we are always in the center of wellness. And when NCDs come in, we are pushed to the edge of illness. And what we need is not a reactive medical system, but a more proactive wellness health system. And you've given us some examples of the kind of work Indian Cancer Society has been dealing with cancer. It's a much bigger disease and a much longer duration in terms of the kind of inputs that need to go in. Thank you for your sharing and the experiences you have told us today. There have been a lot of questions, so we thought we will at least have one or two questions to all of you. Sir, I would like to start with Dr. Mohan. Sir, you both, yourself, Dr. Mohan, and Mrs. Jyotsna, you come with about 40 years of the knowledge and the experience of how India has changed, and you gave us those examples. And the question also is related to that. I have a few questions here which ask me, the kind of NCDs we see in rural areas, when we don't have people who are alcoholic or who are not smokers, but still have the high burden of ischemic heart disease or diabetes. How do we understand this? What do we need to do? And there's another rural doctor who's asked this question. It's so easy to give a diabetic diet, or let's say, I'm giving a prescription of eat regular meals and eat at a certain time, increase your fruits and vegetables. But is that really possible? So how do we, these are this is the first set of questions which I thought you, with your immense experience, and today I believe is the birth anniversary of your great father, Dr. Vishwanathan, and he's the father of diabetes in India. And we want to hear from you. I think the young people out there listening to you will gain a lot. Please.
Thank you. Thank you, Dr. Sukanya. Thank you for those kind words. Well, see, whatever happens in urban India happens in rural India after 5 to 10 years. It's not that India is so different that rural is completely different and urban is completely different. Suppose somebody is marketing in urban India today, they will take the same chips to the rural India in 5 years' time when that market is ready for it. Plus, this urban-rural divide is going away very fast. See, if you take Kerala, Rural diabetes is actually higher than urban diabetes. I already told you in Chennai, poor people are having more diabetes than, so poor rich divide is gone. Young old divide has gone. Everything is coming at young age. 10-year-old fat boys coming with, or girls coming with PCOD or with something else, and adolescent with hypertension already coming, stress there, diabetes there, all coming. What we see at 40, 50, we're seeing at 15 years of age now. So that divide has gone. Urban rural divide has gone. So this is all fast disappearing because India is just one big conglomerate. And also with all this globalization taking place, our youth everywhere are fast adapting to these globalization. Now, if you take the farmers, you may say, well, the farmers are so hardworking. What does the farmer do now? He gets a loan now, he'll buy a tractor, he'll sit on it and he's driving the tractor. You think he's going and tilling the soil like his grandfather did? It has changed. And what is he eating? He also gets his chips and he gets his cola. And if you go and tell them also, because I work in the rural areas, if you go and tell them, you don't do this, you know what's their answer? They say, you haven't been doing it for 20 years. No, let us enjoy it. You have enjoyed all that for 20 years. Now you can come and tell us, don't do that. We have been waiting for these colas to come and for everything to come for love. This is what we've been seeing in television all these years. Now it has come in telling us not to take it. You have enjoyed all that already. Now let us enjoy it. So I don't think rural is so much different from urban now. The original definition of 50 miles away is a rural area. Within 50 miles, you'll see complete urbanization taking place. If you just drive out from Bangalore, you'll see from Bangalore to something, to Devanali, to something. It just goes on and on and on. It's not like the olden days. So I think that concept has completely changed. Habits have changed. People's incomes have started going up. Loans are freely available. Of course, these are all signs of affluence. So when I wrote my first paper, that urban, rural, and showed that the slum people had less diabetes, one of the cynical, it was published in a British journal. So one of the British reviewers, cynically, because he's thinking still of the colonial India and all that. So he's saying, so what is your solution? Make everybody poor in India, then you won't get diabetes, he said. That's his remark that he wrote back. Just make everybody poor in India, then you won't get diabetes. I said, no, I'll make everybody rich in India, but I'll make everybody walk. That's my answer to you, I said. And so I silenced him. A reviewer writes back, make India poor, then everything will be solved, he says. So I think we have to, as we grow, we know that the problems of growth are there. And many of the points that Dr. Govil made are very, very important. And I think this thing, as we, if I'm also, growing in age like her, and so as we grow older, we realize that taking medicine, just writing something, is a very small part of medicine. It is the empathy that we bring to people. It is a kindness that we bring to people. It's the care, the humaneness that we bring to people, whichever specialty, whether it's an addiction, as Dr. Dheeraj is saying, don't say, oh, you are a bad person, you smoked, and yeah, but now he's got hooked to it now. He's also a patient, just like a diabetic or just like cancer patient. He has got another disease, which is also difficult to treat. It's not saying, oh, why did you smoke in the first place? Well, he smoked, he got into it. Now, what can you do now? And for cancer patients, one patient asked me, Dr. Govil, just like you also had a barium, I also had a barium, my wife died. So a picture is there in my room, and the garland and all that. So there are some people who are so attached to her, of course, I don't blame them. It's a patient, and she was a very kind eye doctor with a very big following of her own. So people come to me and they blame me. You allowed her to die. You are a doctor. You should have been more careful. She had breast cancer. 17 years she lived. After 13 years, the disease came back. She lived another 4.5 years with all the meds that you can have. And that's a kind of record that I know of. And then, after she's died, people are blaming me. You're a doctor. You should have looked after her. Earlier itself, you should have diagnosed. You have neglected her. That is why it has happened. Why did you do this? You should have saved it. Then are you not responsible? People have asked me all these questions, So I think it is empathy that we need, and kindness. And also the bad thing that we have got as a profession is because we are cheating people. I think we shouldn't do all that. Basically, for that, you can become a smuggler. You can become so many other things, to make money. There are so many other channels. Why should we come to this profession and cheat people? And we should quit immediately. If it comes to that, we should quit.
Dr. Mohan, number one, I'm not a doctor. I'm just an old busybody who's been at it for 30 or 40 years. And it's whatever I have learned has been learned from people like you, from people in the community, from my colleagues who are all cancer survivors. So it's been an education all my life. I just want to come back to this point about rural and urban. I think what we need to accept is that people are aspirational. When they see somebody with a bottle of Coke, they want that bottle of Coke. They might hate the taste of it. They might hate the first swig on the cigarette that they have taken. They'll cough, they'll spit, they'll do whatever else. But it is that image of a whiskey in one hand and a cigarette in the other that is so ingrained. And then if it is a matter of education, Dr. Mohan, maybe we should hold special classes for our actors and actresses. Doesn't it make you furious when you see the kind of chicanery that they're doing? And Ajay Devgan, who has all the money in the world, Shah Rukh Khan, who has all the money in the world, pretending that they're selling soda when they know they're selling a whiskey or another alcohol brand. I think the truthfulness that you said that it was required of the medical community is required from all of us.
Correct.
We just
Sukanya, I
can't.
think you're muted, Sukanya.
You're saying this, there's one of the participants who's kind of said, so can we all not easily ban all this high instant calorie food and all the sodas and everything? I think that's a question and a topic for another webinar. So we can always.
They've tried taxing it in Kerala. They've tried it. It's not easy,
So that's it's totally something which we need to all think about. We take it as a lesson, definitely, where we will talk to our families, our friends. So in that vein, Mrs. Govil, can I ask you a question? Saying, we see a lot of adolescents taking up tobacco. And when you ask them, they've always kind of seen an elder in their family, or let's say their teacher, who's also smoking. So they see the habit, and therefore they kind of pick it up. So how do we engage with communities? How do we build role models in the communities? Any quick comments from you?
I don't think quitting of tobacco is ever a quick subject, but when they say that they have seen their elders or their teachers do something, when you actually sit down and have a full conversation with them, they realize that it is not that at all. They will not follow their teacher or their grandfather into a dhoti and kurta. They want their blue jeans and they want their checked shirt. So it's the same thing with the cigarettes. It is an image that has been created that they aspire to. And it does not matter that the teacher is smoking or not smoking. They are doing it for a different reason. They might use the teacher as an excuse. Okay, if he can do it, why can't I? And I don't excuse the teacher either. He should not be a teacher if he is indulging in these habits in front of his students. We have laws. That same teacher will get on an aircraft and not smoke for 8 hours or whatever time it takes him to go to another country. What does it cost him not to smoke for the 8 hours that he's in school? If there is a school administration that can enforce that you do not smoke.
I think we would see a lot more of these examples and interventions that have taken place, that work in the coming days. There's a lot of awareness increasing, and I think this change will happen in the coming days. So Dr. Dheeraj, I hope you are in, okay. So
regarding substance use in adolescents, ma'am, why it's very dangerous is that adolescent brain is not fully developed, so it just cannot inhibit the stimulations that it seeks, and therefore an adolescent tries it, he has higher risk of becoming an addict. And secondly, with regards to alcohol, he is not in a position to determine his behaviors. His judgment will be impaired.
Dr. Dheeraj, I think we have lost you. Your connection is.
Hung, yeah.
Yeah.
Bandwidth.
I think we will go on. This is a question to our both Dr. Mohan and Mrs. Govill. If you can give us two examples, kind of that positively impact NCDs. When we talk about community engagement and community level interventions, just any two examples, or conditions, or that you say that if these conditions are there, then definitely there would be a good positive impact with for NCD prevention and control.
So maybe I'll go first. I think all over the world where green spaces have been there, any city, Singapore, London, wherever they've had green spaces, built environment being conducive to health. It's not just physical activity which improves. Cancer will decrease because pollution will decrease. She talked about the blue sky, which you don't see. And if you have the greenery, you will have the blue skies there. The temperature will be lower. So global warming will come down. So I think today, when we are talking about, building new cities and so on, this must be kept in mind and enough importance must be given to this. Because today, climate change is a very serious issue, which is going to affect all of us in the next 20, 30, maybe our next generation is going to suffer a lot. And with it is going to come all these diseases. Cancer is going to come, diabetes is going to come, addictions are going to come, hypertension is going to come, heart disease is going to come, everything is going to come. All NCDs are going to increase. So they're all linked together. We cannot separate one from the other. So I think giving people an opportunity, everybody cannot go to a gym. First of all, it's not even healthy. Inside a gym, when you have COVID, can you go? Whereas throughout this COVID time, wearing a mask, I've gone for a walk. And touch wood, so far, it's been okay. Because right out there, when you're in the open space, how will COVID come? You're wearing a mask and you're walking about, it's still healthy. So people need not give up their exercise, walking or anything, even in the pandemic like this. So that is something which we can do. Second thing is, I've told many governments, many MPs that I met on a flight or ministers and wherever I had a chance, subsidy on fruits and vegetables. If we encourage a country. So then I think I was an NCDIR only. Once I was talking to somebody and then that somebody said, no, we have got excess fruits and vegetables in our country. I said, then people are not getting it. You're talking about excess, and Dr. Prasad Mathur's slide showed 98% of people are not taking it. Then what's happening then? Where is the mismatch then? We have got too much of it, but 98% of people are not taking it. There's some mismatch somewhere, no? And this is not a big rocket science to get green leafy vegetables to people and make it cheap, make it dead cheap, cheaper than water. You can just go and get it anytime you want. If we can spend in that a few thousand crores, and that is well worth investing. Instead of building big monuments and big things, if that money can be channeled into giving just food, clean water to people, I think that will solve a lot of things in our country. It's only a channelizing of the resources. And as I think Dr. Govill said, if you make enough noise, government will listen, because then they'll know the votes are there. And any government will listen. Oh, if people want this, then we also, the Spark thing. First we built the Spark. The government said no. Then a second park came up in Chennai. Then government said, what is this second park and all coming up? Then a third and a fourth came. Then the government said, by the time election was coming, government said, you know what? We are building 100 parks and we'll repair 100 parks. Now, can you beat that? They said. So Chennai got 200 parks. It started with one park, but it became 200 because they wanted the votes. And suddenly, everywhere in Chennai, there were parks, this, that. So we start a movement. Everything starts with Gandhi picking up that little salt, It is very powerful. So I think somewhere, small drops, but eventually it will build up.
Yes, I completely agree with you. I was thinking of the smart city project, which the Prime Minister has started. I don't see health being adequately, highlighted in those plans. It is for roads, it is for buildings, it is for auditoriums, it's for Wi-Fi and whatever. But how about simple things like in your parks? I mean, we talked to the owners of DLF. When they built these multi-storied buildings, they do give a park in that area. but that park is common for children and for old people. And we pointed out that old people don't like being jostled when they are walking. As it is, they are unsteady. So if children are running, you can't stop children from running. So if we could have a little separation where the old people would be on one side and the rest of the area open to children, it would make such a huge difference. They promised, but I have to tell you, I haven't gone back to look at their new developments thereafter. Clean water, clean environment, these are the things that always make a big difference. And in schools, we have a program for schools, which we, on World No Tobacco Day, we ask them to interpret to us on stage for 5 minutes, a small skit on the effects of tobacco. 5 actors, 5 minutes, 5 props. That's it, blank stage. And those kids come up with such wonderful ideas, some slogans, music, everything is there. So it's not that the children don't know. I mean, I take Dr. Dheeraj's point that the adolescent brain is perhaps not as well developed, but I think it's developed hugely in the area of imagination and of interpretation. And it is up to us to channel that. We can't sit back and say that, they're a bunch of hooligans or whatever else. It is us that has to make sure that we do it in the right way.
I think if I can say the smartest city would be the greenest city.
Yes.
Not the one which has the maximum broadband.
Yeah, absolutely right. Yeah.
I'm sure Dr. Dheeraj would agree to the point of children and expression and creativity and art, being an artist himself. Thank you, Dr. Dheeraj, to join back. So do you want to kind of say a few, what you wanted? You were telling us about tobacco and alcohol and addiction.
You can unmute it.
Yes, ma'am. What I wanted to say, ma'am, is that early substance use can become a gateway for use of other illegal substances in the future. So adolescents who use tobacco and nothing bad happens, then think, why not try other things? So it becomes a gateway for illegal substance use in the future. And also, when adolescents in school start using substances, the other good students start distancing themselves from them. And then they gravitate towards deviant peers, and they set themselves up for a bad future because of the peers they select, and they may drop out of school, and that's it. Then there's a downward spiral in their life. So adolescent substance use, we should take it. Teachers should. It's not that we want a punitive action on them, but action should be to help them. The teachers, parents, rather than being punitive, should try to lead them to obtain help. And that would be through, it's not just like, for them, it's not about giving medicine. For them, it is about improving their communication skills, improving skills in which they will be able to assert, and improving their talents, so that they develop positive addictions, like in terms of exercising or fitness, so that they will not go into the deviant path of substances.
Thank you, Dr. Dheeraj. I think we've had a very, very useful 2 hours of sharing of knowledge and lessons for life for all of us who have joined today. I would try to kind of end the session with the preliminary vote of thanks. I would like to start off with our speakers. Please accept my gratitude and a big thanks on behalf of NCDIR for readily agreeing to be a speaker. All of this was planned within 2 weeks. We learned a lot from your sharing today. A special word of thanks to your institutions, Dr. Mohan's Diabetes Center, the CMC Vellore, and Indian Cancer Society, for all the support we have received in organizing this webinar. I thank all the experts, scientists of other ICMR institutions, medical colleges, NCDR Registry Network, the NGOs who have joined us, the citizens who have joined us and participated. in this webinar. We've had a good response of at least 150 to 200 people listening to us through the Zoom and the YouTube link. We assure you that we will come back with another series of interesting topics on NCDs very soon. My sincere thanks to our director for his guidance and encouragement in organizing this webinar, and my special thanks to my team at NCDIR, all of us who work from the IT team, the admin team, the technical and the scientist team who rallied around with all the arrangements. A big cheer to all the participants who have joined us today. Though virtual, we cherish your involvement, your encouragement in joining ICMR NCDIR in this webinar to connect and affirm our goal to work towards the health of the nation. All good things do have to come to an end, but the journey continues. Stay safe, wear your mask, keep social distance, take care of yourselves, family and your community. And as very rightly said by Dr. Mohan, Mrs. Govil and Dr. Mathur and Dr. Dheeraj, please do walk, find some time to take care of yourselves, to walk, to increase your food in terms of fiber and abstain from tobacco and alcohol. Goodbye and take care.